Dear students, we'll start the session starting with the part. The very first question is like about the principle of a surgery, which says that the attractive force is converted into compressive force. Now we have to identify what actual surgical procedure is and for which of the following fractures is done. So firstly, let's discuss this principle as such. So suppose if there is a fracture, there are certain destructive forces. Now destructive forces are the one which actually takes the fragments. Suppose this is one way the fragment will go, and this is another way the fragment will go. This is of course the fracture. So usually the destructive forces are pulled by the muscle. So destructive forces are the one which takes the fragment, and this is something which is not good for fracture healing. Now we do some surgery in which whenever there is an attempt to extract the fragments, it actually brings the fragments closure, and this aids in union of the. So this principle is actually applied for surgical procedure known as tension band wiring, known as W, and the fractures where we do this is of course the one is for fractures of patella, and the second one is fracture of olecranon. Now the assembly of this tension band wiring, we use 2K wires. This is one, second, and then these are passed along the bone. Suppose if there is fracture there like this, the 2K wires are passed, and then we use a stainless steel wire, and this is placed into a figure of 8. Right? So it is something like figure of. So if you do this kind of surgery, the moment there is any force which tries to take the fragments apart, it rather brings the fragment closure. So this is the principle of the surgery. Active forces are converted into, and this aids in. So this principle is actually for tension band wiring, and we mainly do it for fracture of olecranon. You can also do it for medial malleus. So just remember two fractures at least. Number one, number two, olecranon. So these are the two fractures for which you should remember tension band wiring. Then coming to the next question, patient presented to the OPD with pain and complaint in the left shoulder following fall on outstretched hand. There was a fracture of clavicle, which is X-ray, and then was asked like what commonest site of fracture. Before we go on to discuss the fracture proper, there is one term, and that is known as foosh. So this foosh injury is nothing except fall on outstretched. So fall on outstretched hand, this is in short we write it as foosh injury, and this is one principal way in which we have fractures of the upper limb. So it can involve any bone, it can involve fracture, right, or supracondylar fracture, this any injury, Colles even. So this foosh injury is very common for injuries of So, most of the time whenever you will have a history of fractures involving upper limb, definitely you are going to case history. So, Fuchs injury. Now, coming to the improper, if you look at the image, here you can see that the clavicle is fractured, of course. One fragment of the clavicle, this is another fragment. So, if you look here, this is medial third, and this is, so obviously the most common site of fracture clavicle comes out to be the junction of medial 2/3 and lateral. Sometimes in MCQs they won't give you this option, then what? In such cases you should go for lateral, right? So, priority wise, the most common site of fracture is junction of medial third with lateral 1/3, right? So, it can be the first, and if it is not there in the options, you can choose fracture lateral. Either of the two you can take as per the given. Now, apart from this, what else you need to know? One thing is why this site is particularly common. Why this particular site is common, like the junction of medial 2/3 with lateral 1/3. So, for that you need to understand the cross-sectional anatomy of clavicle, because if you ever have seen a clavicle, it is rounded in middle 2/3 and flat in lateral 1/3. So, that junction point, the point of transition from that circular bone to a flat bone, that is the one of the weaker areas, and therefore the bone tends to fracture from that particular site, right? Now, apart from that, you can see the displacements are quite obvious. If you see, the distal fragment goes, the lateral fragment, pardon, the lateral fragment goes downward, and the proximal, the medial fragment, it goes upward. So, if we talk about the displacement of fragments, so if you see here, the medial fragment going upward, it is going upward, and that is because of the pull by the sternocleidomastoid muscle. So, this is because of the pull by sternocleidomastoid, and if you look at the lateral fragment, the lateral fragment is going downward, right? So, it is going downward, and this is because of gravity, the effect of gravity, gravity. So, these are the typical displacements which you will see in a case of fracture of clavicle. Now, I think management wise, all of you must be knowing that it is quite one of the easy fractures to manage. So, what we need to do, simply we need to give a figure of 8. Just give a figure of 8 and just make sure that the figure of 8 is on the back side, not on the front. So, and this is one fracture which unites readily, and even if there is any sort of malunion, it does not hamper with the functions as such. So, malunion, even if it is there, it is of no concern to us. So, functionally it is not a problem at all. So, I think fracture clavicle is quite important. One should be very clear with the basic concepts, at least the ones which I have discussed with you. Now, moving ahead, taking another question, patient with recurrent dislocation. So, there is possibility of the dislocation of the shoulder again and again, and when the doctor tries to abduct and externally rotate, patient does not allow the doctor to do so. So, if you look at the movements, abduction and external rotation. So these two movements at the shoulder, these two movements are the one which actually promotes dislocation, especially the anterior dislocation. So the moment the doctor tries to do abduction, external rotation, the patient is very apprehensive that now my joint is going to dislocate. So we will stop the doctor, please don't do this, or he will just resist the procedure fearing that my joint will dislocate. So there is apprehension, there is fear, and therefore we call this test as the apprehension test. So the moment the orthopedician tries to abduct and accelerate the upper limb, the patient will resist movements fearing the possibility of shoulder anterior. This is apprehension test and very commonly seen in recurrent dislocation. Now, apart from this, you should know few facts about shoulder dislocation. Now, shoulder is the most common joint in the body to dislocate. One of the important facts is that it is the most common joint in the body, and once it is dislocated, and if you don't reduce properly or if you don't manage it properly or adequately, it has a tendency to undergo recurrent dislocation. Most common joint to undergo recurrent, right? So it is the one which commonly undergoes dislocation, and it has a tendency to undergo recurrent dislocation, right? Now, the most common variety, the most common type which we see in clinical practice is anterior, and here the head of humerus lies below the coracoid process, so it is known as sub. Right? So anterior subcoracoid is the commonest variety. Then we have certain tests to check for shoulder dislocation. One is Dugas test, and in Dugas test the patient is not able to touch the tip of opposite shoulder, right? Because there is no movement at the shoulder joint, so it is not possible for the patient to touch the tip of opposite normal shoulder. So that is Dugas test. In Hamilton test, we place a ruler on the lateral aspect of the arm, and if the shoulder is in normal position, it is not possible to touch both the tips of lateral epicondyle and the acromion process simultaneously in a straight line. So that is Hamilton ruler test. In Callaway's test, because of the shoulder dislocation, the circumference or the vertical circumference of the axilla, it increases because the head of humerus is also lying there, right? So these are three which are done for shoulder dislocation. And then coming to the treatment, any dislocation anywhere is a surgical, it's a clinical emergency. So we need to do emergency reduction, right? And the procedure which we do commonly in clinical practice is the Walker's maneuver, in which the sequence of step can be remembered by the mnemonic team. So traction, external rotation, adduction, medial rotation. So this is in short about shoulder dislocation. And if someone asks you about the most commonly injured nerve, then your answer has to be axillary. I think this much is enough for shoulder dislocation. In the test in which the orthopedician is trying to abduct, accelerate the upper limb, the patient will not allow to do that. It's the apprehension test. Okay. So this much is all about anterior shoulder Now we will move further on to next question, and the case history starts with a young male who is epileptic, and following a seizure he had developed pain in the right shoulder, and when the examination was done, it was seen that the right shoulder was adducted and internally rotated. So, adducted and internally rotated. Now, why I have kept this question over here? Because we just discussed anterior shoulder dislocation, and in which we discussed abduction and external rotation. Now, look here, the words are adduction and internal rotation. So, the terms are exactly opposite to what we have discussed in anterior shoulder dislocation. And secondly, in a clinical setting of epilepsy or electrocution with adduction internal rotation, it always goes in favor of the diagnosis of posterior dislocation of. So, for posterior dislocation of shoulder, you need to just remember 2-3 things. Posterior dislocation. Now, this is very rare variety, right? This is a very rare variety. You can just write. Very rarely we see cases of shoulder dislocation. It is commonly seen in epileptics during a seizure attack, epileptics, or if there is an electrocution, electric shock. So, these are the predisposing factors. Whenever you have a case history which starts with patient with known case of epilepsy having a fit, or if there is an history of electrocution, think of the possibility of posterior shock. Now, on X-ray, we see an important sign that is known as the electric bulb sign, just because of the typical displacement of the humerus. So, this much is enough for posterior shoulder. And since we have discussed anterior, so I thought of keeping this particular question, so at least we can discuss a couple of words for posterior shoulder as well. Then moving forward, the case history starts with post-menopausal woman, right? And there is a fall in bathroom, and there is this Fuchs injury. So, this is Fuchs injury, and she developed a bony fracture. Now, whenever you have a case history of a post-menopausal lady or an elderly male, you always think of the possibility of pathological fracture, which is usually osteoporotic fractures in an elderly, right? So, this particularly is a case of osteoporosis, because we know that in an elderly lady there is deficiency of estrogen, which promotes osteoporotic phenomena, and that makes the bone quite weaker and very vulnerable to fractures. So, in osteoporosis, we are mainly interested in discussing few conditions. One is fractures of vertebrae, right? They can be seen. Then fracture neck of femur, and third is fracture Achilles. So, these are the three commonly seen fractures in an elderly patient. It can be a male, it can be a female, but yes, of course, in a post-menopausal lady, the effect of osteoporosis more seen, right? So, considering the upper limb fracture, we can go for Achilles fracture in this particular. So, we can see pathological fractures in vertebral bodies, we can see pathological fracture in neck of femur, and the underlying process is osteoporosis. So, just few words for Achilles fracture. We take it is at the lower end of radius at corticocancellous junction. Now, how you will identify given X-ray as a case of fracture Colles? Before that, just of this before. Now, what you need to do, you have to look at the fragment. So, suppose this is the proximal fragment, and then you need to look at the displacement of the distal. This is proximal and this is distal, and we look whether the distal fragment has gone volarly towards the palm or dorsally towards the back. We have to just look at that first. So, in a case of Colles fracture, it goes dorsally, it goes backward, right? So, the moment you find the dorsal displacement of the distal fragment, you can say that this is a case of Colles fracture, right? And this dorsal displacement actually gives the dinner fork deformity. So, this is one thing. Now, what if the fragment goes volarly? It goes on the anterior aspect. What we will see then? If it goes volarly, suppose if it is lying somewhere here, suppose if it is lying somewhere here, you say this, then is volar, then this is known as Smith's fracture, right? So, here it will be known as Smith's fracture, and as you can see that the displacement of the fracture or the distal fragment is opposite to Colles. Therefore, this is known as reverse, right? So, that's the reason why we call Smith fracture as the reverse Colles, because we look at the displacement of the distal fragment. If it is coming towards the volar side, it is known as Smith. If it is going backward towards the dorsal side, it is the Colles fracture, right? So, this is how a lower end radius fracture, whether it is Colles, whether it is Smith, we have to make a decision based on the displacement of distal fragment. Clear? So, that is very important. And since the displacement of the distal fragment in a Smith fracture is opposite to that what we see in Colles fracture, Smith fracture is also known as reverse Colles. Then in Colles, we saw that there is dinner fork deformity. In cases of Smith, we will see garden. So, please remember this much, Colles and Smith. It will cover the important points related to exam. Anyway, then moving on to next question. A patient had pain in the right hip joint, few months, and when the examination was done, it was noted that there is true shortening of, then the lower limb was in an attitude of flexion, adduction and internal rotation, and specifically there was no history of trauma. So, if we can just write down these words, number one, there is true shortening, and number two, there is flexion, adduction and internal deformity. And third, you can also write no history of. So, we have 3 points in this answer. We'll take the points one by one. Now, what do you mean by the word true shortening? Whenever we want to measure the length of a lower limb, we always measure from anterior superior iliac spine to the medial malleolus, and we compare it with the other side. So, when we are saying that there is true shortening, means the actual length of the limb, number one. Number two, if you look at the deformity, flexion, adduction, internal rotation. So, if I just write a short word for this, this is fader. This is fader. Now, many of you must have heard that fader after injury is posterior hip. So, the moment if there is any injury to the hip, patient having fader deformity, the answer has to be of hip. But since in this question specifically it has been written that there is no history of trauma, so we have to exclude this, cannot be the answer. Now, okay, let's go back to the options, and they are mentioning certain stages of the tuberculosis of hip. So, certainly this is a case of TB of hip, and now we have to discuss the different stages so as to reach up to the answer. For ease of understanding, I will divide the tuberculosis of hip into three stages. So, one is the stage of synovitis. This is the stage of synovitis. Second is early arthritis, and third is late arthritis. These are the three stages. Now, what happens in the first stage? The pathology, I write the word pathology here, there is inflammation of synovium, right? In this stage, there is inflammation of synovium. Now, what will happen? The function of synovium is to produce synovial fluid. So, whenever there is an insult to synovium, what it will be doing? It will be producing more of synovial fluid. So, it will react by producing more of synovial. Now, the joint space is limited by a capsule and it cannot stretch much. So, just to accommodate this excessively produced synovial fluid, joint will assume position in which it can accommodate excess of synovial, right. So, the hip joint will assume a position in which it can accommodate this excessively produced synovial fluid. And for hip joint, that position is flexion, abduction, external rotation. So, that position is, in short, you can write Faber: flexion, abduction, external rotation. Okay. So, this is the position of the hip joint which can accommodate large amount of synovial. Now, what will happen the moment the patient assume this posture for the lower limb? From a distance, it appears as if the limb is lengthened, right. So, it seems as if the limb is longer than the opposite normal. So, this is known as apparent lengthening, because if you measure the limb length of both the sides, it is equal. It is only just that from a distance it looks longer. So, we will use the word apparent. If you measure the length, it will be absolutely equal to the other normal side, right. So, this is stage of synovitis, where you will find Weber deformity and apparent lengthening. Now, if the condition is not treated at this stage, what will happen? The patient will move ahead to the stage of early arthritis. It means there is early involvement of the joint fracture. And what happens here? There is irritation of the surrounding muscles. So, because of the inflammation of the joint, there is irritation of the surrounding muscles, and the muscles, they try to move the hip joint in the direction of their action. Now, we know that there are flexors and extensors of hip joint, there are adductors and abductors of hip joint, and there are external rotators and internal rotators of the. Now, the muscles which are more powerful than the opposite antagonist muscle, they will pull the hip joint in the direction of their action. And in relation to the hip joint, the powerful muscles are the flexors as compared to extensors, right? Adductors as compared to abductors, and internal rotators as compared to external rotators, right? So, flexors are more powerful than adductors, are more powerful than abductors, and internal rotators are more powerful than. So, now what will happen? These muscles, they will pull the limb into an attitude of flexion, because flexors are more stronger, adduction because adductors are more stronger, and internal rotation because the internal rotators are more stronger, right? So, the muscle groups which are more stronger will pull the lower limb into direction of their action. So, what kind of deformity we are getting here? Now, this is Fadir. Clear? So, here we are getting a Fadir deformity. Now, since the limb has been assuming this kind of posture, flexion, adduction, internal rotation, so from a distance it appears as if it is shorter than the others normal. So, this is known as apparent shortening. Right? Again, if you measure the length of the affected side, it will be equal to the normal side. It means length of both the sides are same. It is just that it appears short. We have used this word apparent, right? And the limb length will not alter because there is no bony damage as. Now, if the person moves onward to further stages, the stage of late arthritis, where there is actual bone damage. Now, here there is actual bone damage to the head of femur. So, what will happen? Everything will remain same. We will have the Fadir deformity here, the same, but since there is actual bone damage, so when you will do measurement, you will find true shortening. So, only in the late arthritis stage, because of actual bony damage, you will find true shortening. So, this is very important. So, the moment you find a case with true shortening, Fadir deformity, the answer has to be the stage of erosion of TB hip or the late stage or advanced arthritis stage. Okay. So, this is how you have to remember the stages of TB hip, their clinical manifestations in terms of the attitude of the lower limb and the limb length. Limb length will always be affected only if there is actual bony damage. So therefore, we find true shortening in the late arthritis. So please remember this much, and just let me summarize 2 points. In first stage, Faber apparent lengthening. In second stage, Fader apparent shortening, and in third stage, Fader with true short. Please remember this much, and this will summarize the entire. Right. Let's move on to another question. A 5-year-old child with knee pain, irritability, and gum bleeding. Right? So the moment you find the word gum bleeding, I think most of you can get up to the answer. So, and when we took an X-ray, we find significantly thin cortex and a white line at the metaphyseal. Right? So this all presentation very specific for Scurvy. Now, everyone knows that in Scurvy there is defective collagen formation, and that manifests as gum bleeding. In terms of X-ray findings, what we can see, and even in this MCQ it has been mentioned, a white line, and this is white line of ankle. So if you look here, this is the white line of ankle. Then we can see pencil in cortex. See, the cortex are thinned out. Then you can see a falcon spur, and you can see this black shadow here, that is actually Trummer-Feld. So very classical X-ray of Scurvy. You can also see subperiosteal hemorrhages or Wimberger ring sign. So this is all for Scurvy. So please remember the radiological features of Scurvy. Then an obese woman came to OPD with pain in both the knee joints and can hear sounds click while walking. Pain tends to be more severe while she is going downstairs, and X-ray is shown. So now here, if you look at the keywords, one is obese, then some problem with the knee joint, and which is more particularly when she is going downstairs. So if you look at the X-ray, just look at the joint space here and just look at the joint space here. Now this is known as reduction in joint space. So the articular ends of the femur and tibia, they have come quite closure, and that happens because the intervening cartilage has degenerated. Okay, so the cartilage which is actually present over the bones, right? This is, we know that this is hyaline kind of cartilage. So as it degenerates, as it dies away, it brings the bony ends closure. And since these bony ends, they have nerve supply, so the moment when there is movement at the joint, whatever, like knee in this case, so whenever there is movement or whenever there is rubbing of those bony ends, it produces severe pain. So that is very classical for osteoarthritis. Now this word osteoarthritis, because think all of you must be knowing that itis means inflammation. But this term is a misnomer here, because as such there is no inflammation, it is just a normal wear and tear the cartilage with age. So this is osteoarthritis, and for osteoarthritis just remember few things. It can be primary when there is no underlying cause, and this is the one which is very commonly seen in clinical practice. It can be secondary when a articular fracture has not been managed properly. So mismanaged intra-articular fractures, this is the common cause. And therefore we always say that for intra-articular fractures we should go for ORIF, open reduction internal fixation, where the principle is to maintain the articular congruity. So that is very important. That's why we always stress for the need of accurate reduction and maintenance of the articular congruity, right? So these are the two varieties. And then if we talk about the joints which are commonly involved, it differs. Like in Western world, the hip joint is commonly involved, whereas in Indian setup there is common involvement of knee joint. We see more cases of knee joint osteoarthritis. Then coming to X-ray features, one we have already seen that there is reduction in joint space, and here we can also see that there is some opening up of the lateral aspect of the knee joint. So that indicates that there is some varus deformity. This indicates that there is some varus deformities. So if you ever see a case of knee osteoarthritis, you can very well appreciate the varus deformity at the knee joint. Now coming to the treatment, once patient is having chest pain, means he is having pain 24 hours. So in that case we need to go for total joint replacement, total knee replacement in this case. So chest pain means 24 hours pain, so we need to go for replacement. So that is the usual management. And once the patient says that I am having pain throughout the day, throughout the night, then this procedure might. So this is in short about osteoarthritis. Now moving on to next question, again a very favorite question. A non-vegetarian person with redness and pain at the right grade. So the moment you find the word grade 2, right? So if there is any pain and swelling involving the grade 2 or the metatarsophalangeal joint or foot, then always and always you think of the possibility of gout, right? And if we go further, in this case we can say that the uric acid is 10. Now the normal acceptable upper limit for uric acid is 0.5 to 7, somewhere around that. So 10 is of course a little higher, and then there is past history of similar episode. So this is a case of chronic gout. So the point which favors the diagnosis of gout here, one is non-vegetarian, especially the people who consume red meat. Then the second point is pain, swelling, MTP joint, that is grade 2. Then raised uric acid. These are all in favor of the diagnosis of any value more than 7 can be taken as raised serum uric acid. Now, here the patient already had taken analgesic, and now doctor has given one more drug by which he is trying to reduce down the formation of uric acid. And since this is a case of chronic gout, because there are previous episodes as well. So, for chronic gout, we can give allopurinol. Now, this is very important to remember that allopurinol is not given in acute cases, right? Please be very careful in this. In acute gout, we don't give allopurinol. We give allopurinol only in chronic cases. So, for acute, we can give painkillers, we can give steroids, we can also give. It's only in chronic gout we will give allopurinol, which actually inhibits the enzyme xanthine oxidase and therefore reduces the formation of uric acid. Reduces uric acid formation by inhibiting in. So, this much for gout is okay. And yes, if you look for the crystals, you will find needle shaped negatively birefringent crystals. So, needle negatively birefringent crystals, which are made up of monosodium. So, I think this much is enough for gout. And again, gout is a very important topic. Again and again, you are in one or another. Now, moving on to another question. Alcoholic patient slept with keeping his head over the arm, and when he woke up next morning, there was radial nerve paralysis. Now, this is what kind of nerve injury? Now, here what we can presume from the case history, that there is no anatomical injury as such. It is just that there is some physiological disruption of the activity, and that is known as neuro. So, if you look at this is actually the Seddon's classification. So, this is the nerve as such, and this is the. So, in neuropraxia, nerve anatomy is okay. Anatomy is okay. It is just that the physiology is disturbed. Means there is no conduction across the nerve. The physiology is disturbed, and since the anatomy is okay, we can expect complete recovery. Complete recovery is expected. So, neuropraxia is one of the kind of nerve injuries which carries good prognosis, because we can expect 100% recovery, as the anatomically the nerve is quite okay. It is just that there is transient or temporary disorder of conduction across the nerve. Now, the another one is in which you can see that the axon is cut. When the axon is cut, it is known as axonot, and if the entire nerve is cut, this is known as neurot, right. So, the entire nerve is cut, this is neurotmesis, and obviously this will carry very poor. Clear? So, this is a Seddon's classification of nerve injuries. So if there is any compression over the nerve leading to disruption of the function of the nerve, that is usually a case of neuropraxia. If only the axon is cut, that is axonotomesis. If the entire nerve is cut, as may be seen during a operative procedure when there is the abnormal location of the nerve and accidentally it is cut, then it is a case of neurotomesis. Let's move on to another question. A young lady has tingling sensation in the thumb, index finger and middle finger, and this abnormal sensations can be aggravated if the wrist is palmar. So, if the wrist is palmar flexed for 1 minute, the symptoms aggravate. Now, if we look at the area of this paresthesia, this is right thumb, index finger, middle finger, and we can just add half of ring finger. This all is territory of cutaneous distribution of median. So, whenever a patient comes to us with tingling, numbness, burning sensation in this much area, lateral 3.5, volar aspect, it suggests that there is some compression of median nerve. And if we palmar flex the wrist for 1 minute, it will further aggravate the compression over the median nerve and the symptoms will be more pronounced. So, this particular test is known as Fallin test, right. So, this is Fallin test, and this actually is done to aggravate the compression of median nerve in the carpal tunnel. So, this case is actually carpal tunnel. So, carpal tunnel syndrome, you can look in this image, there is compression of the median nerve as it passes through the carpal tunnel. Now, anatomy of carpal tunnel, the fibro-osseous tunnel. On the lower side, we have the carpal bones. On the lower side, we have carpal bones, and on the top, there is a flexor retinoculum. So, there is a flexor retinoculum here, and therefore, this area, whole area is converted into a tunnel. So, this is the tunnel as such, and through this tunnel there is passage of the median nerve along with the long flexor tendons. Now, sometimes, now this tunnel is a closed space. In certain conditions like pregnancy, or you say hypothyroidism or amyloidosis, there is possibility that there is some aggravation of the compression of the median nerve within the carpal tunnel, and then it leads to the carpal tunnel syndrome. So, this is the classical area of paresthesia if the patient is having carpal tunnel syndrome or the compression of median nerve in the carpal. So, you can see the thumb area, index finger, middle finger, and half of the lateral aspect of the ring finger. So, please remember this lateral 3.5 rule, polar aspect. So, this is the typical distribution of nerve, and whenever there is compression of the median nerve, patient will have altered sense, burning, sense, pricking, numbness in this particular area. That goes in favor of the diagnosis of carpal tunnel syndrome. In the moment you palmar flex the wrist, aggravating the compression over the median nerve, the symptoms will be more pronounced. Now, what we need to do for carpal tunnel syndrome? For carpal tunnel syndrome, we can give a splint, it is splint, so as to prevent flexion at the wrist. If this doesn't work, then we can go for local steroid injection because of its anti-inflammatory properties. And if this doesn't work, then we need to do a decompression surgery. Decompression surgery means we have to cut the reticulum, and that will make space for the nerve to breathe. Right. So this is in short about carpal tunnel syndrome. Symptomatology is quite classic. One can easily identify that. Right. So carpal tunnel syndrome is for median nerve. And please don't confuse carpal tunnel syndrome with cubital tunnel syndrome, because cubital tunnel syndrome is for ulnar nerve. So you can remember U for ulnar nerve. Right. So carpal tunnel syndrome, median nerve; cubital tunnel syndrome, depression neuropathy, ulnar nerve. Now, patient was operated on elbow, but later on he was unable to flex the index. Flexion of the index finger was lost. And whenever you find any nerve injury resulting in any affection of the index finger, just think of one term, pointing index. And the moment you recall that term, pointing index, it is very easy for you to identify the nerve or to understand of what nerve we are discussing. So here the patient is not unable to flex the index finger. It means the flexors of the index fingers are paralyzed. And the flexors are flexor digitorum profundus and flexor digitorum superficialis, which are supplied by median nerve. So it means there is median nerve injury. That is how you can reach up to the conclusion that this is a case of injury to median. Now here, now this all fact can be summarized in terms of certain tests or in postures. So one is, of course, as I told you, pointing index, right? And second is Ochsner clasp. The moment you tell the patient to make a clasp, the index finger will remain extended like this. This is because the flexor digitorum profundus and digitorum superficialis are parallel. So this is one thing. Then somewhat similar is sign of benediction. So these are certain terms which can be discussed based on this concept of analysis of FDS and FDP. Now one should remember one thing here, that FDP is a hybrid muscle. It is a hybrid muscle and it has got a dual nerve supply. It has two halves, lateral half and medial half. The lateral half is supplied by median nerve, the AIN, median trochleus nerve, and the medial half is supplied by the ulnar. So therefore, whenever we talk about the paralysis of FDP, it is going to affect these two fingers only, because medial half is supplied by ulnar nerve and that is spared. So these two fingers will not be in terms of FDP. FDS, all fingers are gone. So this is the basic presentation if there is injury to median nerve related to long flexor paralysis. Also we can have other terms also, like wasting of thenar eminence or ape thumb deformity. So this is particularly in relation to FDP and FDS, flexor digitorum profundus and flexor digitorum superficialis. So please remember. Now, another important segment, and that is bony tumors. And always and always we have. Now, the question is eccentric epiphyseal tumor which can extend up to metaphysis. So, the moment you find double E, eccentric epiphyseal, the moment you find double E, think of giant cell. Now, what does this word eccentric mean? Eccentric means, suppose if this is a bone, suppose this is a bone, and if the tumor is more onto one side, this is known as eccentric. Right? So, if the tumor is more towards one side, it is known as eccentric. And I think epiphyseal is clear to all of you. It arises in the epiphysis, and this particular tumor then extends towards. So, this is giant cell tumor, and if you look here, this is a classical picture of giant cell tumor involving the lower end of radius. You can see that the tumor is more towards one side. So, you can say this is eccentric. It is arising from epiphysis, so it is epiphyseal. Now, what extra do you need to know here? I think most of you must be knowing about the soap bubble appearance. And that is because the tumor is a lytic lesions and it has trabeculation something like this. So, this gives rise to the typical soap bubble. So, this is one thing. Now, there are some other points which you remember. Number one is about the histology. This is very important because we have most of the time. Now, here whenever we will do histopathology of giant cell tumor, we will see two kind of cells. One is mononuclear cells, are spindle shaped cells, and the another one are the multinucleated giant cells. Previously, by looking at these giant cells, and these were mistaken as the tumor cells. So, these were mistaken as tumor, and hence the condition was named as giant cell. So, the giant cells, if I draw a giant cell, so giant cell will like this, a big cell, and it will have multiple nuclei. This is giant cell. This is a giant cell. And if I draw a mononuclear cell, so previously these giant cells were considered to be as the humerus cells, and therefore the nomenclature was the giant cell tumor. But these are not the tumor cells, these are actually the tumor. So, that nomenclature of giant cell tumor is an erroneous nomenclature, because these giant cells are not the tumor cells, the mononuclear spindle shaped cells, actual tumors. And it was also presumed that these giant cells might be having some osteoclastic activity, and therefore it was also named as osteo. So, giant cell tumor, osteoclastic, same thing, and this is important in relation to, please remember. Now, coming to treatment, especially in cases of lower end of radius, we need to excise this part, and we have to take a fibular graft from the opposite side, and it has to be fixed in an inverted position so that the head of fibula is somewhere here. So anyway, so please remember this much for giant cell tumor, a very important entity from exam point of. Then next question, elderly patient with hypercalcemia and features of renal insufficiency, RBC count is low and X-ray is shown, most likely diagnosis. Now what we can see here, that there is raised calcium levels, then there is renal failure, renal insufficiency features, RBC is low because of the renal involvement, and particularly in the X-ray we can see multiple punched out lesions. You see these black densities, these are known as multiple lytic punched out. The moment you have this kind of presentation, especially over the skull X-ray, you can very well say that it is a case of multiple myeloma, which is a plasma cell dyscrasia. So multiple myeloma, and for multiple myeloma, remember one more important thing, why it is being discussed in orthopedics, because it is the most common primary malignant bony, right? So if I say most common primary malignant bony tumor, the answer has to be multiple myeloma. If I remove the word primary from here and if I simply write most common malignant bony tumor, the answer will be metastasis, right? So this is in relation to malignant tumors. If I use the word most common primary benign bony tumor, the answer will be osteoid osteoma. And if I remove the word primary from here, I write most common benign bony tumor, the answer will be osteo. Clear? So simple change of few terms changes the entire meaning of the question in consideration. So please remember this much. Anyway, so this is for multiple myeloma. Whenever you see a case of, whenever you see a skull X-ray with punched out lytic lesions in a typical setting of raised serum calcium, renal insufficiency, the diagnosis. Then next question, a patient came with lower back pain, and when you did X-ray of spine, you saw sclerotic lesion. Now, sclerotic lesions, you can also call them plastic lesion. Means there is formation of new bone, and new bone will appear very white. This is all the whiteness which you see. This is all new bone formation, right? So this is known as osteoblastic metastasis, because usually what we see in cases of metastasis, that is usually osteolytic. Whenever we see metastasis from tumors like carcinoma, endometrium, and breast carcinoma, the tumors, when the tumor cells reaches the bone, they will destroy the bone, and therefore the term is osteolytic metastasis. But especially in cases of carcinoma of prostate, cancer cells, they will promote new bone formation. So this is very unique concept. So there is new bone formation, and therefore we use the word osteoblastic or sclerotic metastasis. So this is very unique, please remember. Then next question, 15 years old boy with a mass in distal femur is given, what can be the diagnosis? Now, if you look at the age is 15 years, and there is involvement of the distal femur. And if we look at the X-ray, we can see radiating lines, something. This is known as the sun ray appearance. This is sun ray appearance or the sunburst appearance. And I think most of you must be knowing where we see this sun ray appearance. So this is a very classical feature of osteosarcoma. Osteosarcoma, a very aggressive or very malignant tumor. And most common patient is around the knee joint, where lower end of femur is the first site to be affected. Lower end of femur first, and second is upper end of. On X-ray, you will find two things. Number one is, of course, the sun ray appearance, which is actually the calcification along the blood vessels, the Sharpie's fibers. And the second is the Codman's triangle. Codman's triangle, whenever there is lifting of periosteum, there is a triangle, something like this. So this is known as Codman's triangle. And since this is very aggressive tumor, so at times it presents with metastasis, maybe in lungs, and if you do X-ray, you will find cannonball shadow. Now, prognosis is extremely poor. We can do amputation and other surgeries, but despite that, death occurs. So this is in short about osteosarcoma. It happens to be very malignant. Now, a child presented with multiple fractures and his sclera were blue. So this condition is actually osteogenesis imperfecta. Now here, please remember one thing, that in this particular condition there is defect in collagen synthesis and there is blue sclera, but this blue sclera can be seen in normal child also, normal infant also. This doesn't mean that if you see an infant or a child with blue sclera, you will label him as a kid. Don't do that. Right? So here we can see multiple fractures, and then consequent deformities. So this is a typical case of osteogenesis imperfecta. We can try putting some biodegradable rods, which are known as BD rods, but osteogenesis imperfecta. Then next question, an army recruit, right, and 6 months into training, and there is pain at posteromedial aspect, and there is acute point tenderness, and the pain aggravated on physical. Now, what is the likely diagnosis? Now, firstly, look at the occupation. It's a case of army recruit undergoing vigorous training, pain in area, and which increases with activity, and there is acute point tenderness, means the pain is felt only at one point. If you press that point, pain will be very severe. Acute. Whenever you have these kind of words, it goes in favor of stress fracture. And what actually is stress fracture? Stress fracture is also known as March fracture, And march fracture means like people who used to do a lot of march past or parade, like army, these recruits. Whenever they do a lot of march past or parade, they can cause, they are liable to have stress fractures, and the commonest site of stress fractures can be involving the second or third metatarsal or lower end tibia. These are the usual sites of stress fracture. So if you see any case history starting with army recruit or police recruit presenting with pain in the foot or in the shin of leg, think of the possibility of stress fracture. Stress fracture means that whenever we keep on giving repetitive stress to a particular region of the body, to a particular bone, it undergoes, that is known as stress fracture, or particularly in this case it is known. Then moving on to the next question. A patient was on long steroid therapy and now is complaining of pain in both the hip joint. This is a case of avascular necrosis of head of femur. Now most of you read avascular necrosis in terms of trauma. Avascular necrosis, that AVN, as the name suggests, A means vascular, means blood supply. What happens? There is interruption of the blood supply to a part of bone, and then it undergoes necrosis. So that we have read in terms of trauma, and especially fractures like neck of femur or of talus, fracture through the waist of. So this is the usual AVN in traumatology which we usually discuss. But sometimes if patient is on long-term steroid therapy, he is also liable to develop non-traumatic AVN of the head of femur. So this can be a possibility. Not that only in traumatic cases we can find AVN. It can be seen in non-traumatic conditions as well, especially steroid therapy or Kaizen's disease. Now what actually we see in X-ray? If you look here, this is normal and this is AVN. Now on the normal side you can see such a rounded contour of the femur, whereas if you look on the other side, it is irregular and depressed. Right? So one thing, you can see the contour of the head of number one. So if you have to look on the X-ray, at the contour or the shape head of femur. And number two, you will look in the density of head of femur. Right? So normally it should be uniform density, but if you look here, you can see white is in the AVN, too much of white patches, and that actually suggests that areas have undergone avascular. Right? So very easy to identify on X-ray. But yes, the changes on X-ray are appreciated quite late. If we have to appreciate the changes a little early, we can go for MRI. So this is AVN, avascular necrosis. Now, a 5-year-old child presented with genu varum deformity. Osteopenia was seen. Vitamin D is less, and alkaline phosphatase is high. Vitamin D is less and alkaline phosphatase is high. Now, whenever you see a case of child with genu-varum deformity and osteopenia, low vitamin D, low calcium, raised alkaline phosphatase. This is a typical case of Rickets. This is a typical case of, I think genu-varum deformity is quite obvious to all of you. Which is also known as bowing of legs, is also known as bowing of. In Rickets, we can have any deformity. We can have genu-varum or even wind-swept deformity. But yes, genu-varum is the usual complaint, because the pathology in Rickets is that osteoid is good, but since there is deficiency of calcium, so mineralization is poor, and as a result of this, the bones are quite. And if such a child starts wearing weight, under the effect of body weight, the lower limb bones they bend, giving rise to the typical bowing of legs, or is known as varum. Right? So classical presentation of Rickets. Then a young patient having tumor in right shin associated with pain and tend to relieve after taking aspirin. This is classical presentation for osteoid osteoma, and since it dramatically responds to aspirin, so it is also known as aspirin tumor. It is also known as aspirin. Now, what we see on X-ray, if we take X-ray or CT scan, we can see, now this is cortex. You can see this is cortex, and in the cortex we can see a nidus. Black shadow is a nidus, known as, right. So what we write in description, that there is a cortical nidus, and the size is somewhere around 1, and this cortical nidus is well appreciated in a transverse section. So if we take the transverse section, you can see a black cavity. This is cortical. So the classical presentation, and you can see this is tibia. Of course, so tibia is the usual site, and you can see a nidus in the cortex, cortical nidus, and the patient have pain especially at night, relieved by taking aspirin. So this is on the base of this particular feature, it is also in tumor. So please remember osteoid osteoma, and as I told you before, this is the most common primary benign bone. Yeah, so osteoid osteoma. Then patient has RTA, and on examination, the lower limb was in external rotation and appeared lengthened. So external rotation, and we can also write one more word to make it more appropriate. We can write abduction, external rotation, and lengthening. This goes, and if you write it like in short form, it will be like Faber, right? And we can write it Faber because at times there is also flexion. So this is kind of Faber deformity. Now, most of you must have studied Fadir for posterior dislocation of hip. Most of you must have studied Fadir for hip. Now, Faber has to be remembered for anterior hip dislocation. Please remember this for anterior hip. dislocation. And when we say anterior hip dislocation, it means the head of the femur is lying anterior to the acetabulum. The acetabulum behind, and the head of femur, it has moved anterior to the acetabulum. So that is anterior hip. So this is anterior hip dislocation. And if you look in the images, this is given for reference purpose. This is after injury, and this is after reduction. So post injury, you can see that now this is a case of bilateral hip anterior dislocation. You can see both the lower limbs are abducted. Means if you draw a line from the midline, both the lower limbs are going away. So that is abduction. You can see some flexion at the hip joint and external rotation also. See external rotation, and external rotation, you can look at the lateral border of the foot. Just see the lateral border. Lateral border of the foot is touching the couch. So this is external rotation. So abduction, external rotation with flexion is anterior hip dislocation, and flexion, adduction, internal rotation, posterior hip dislocation. Please remember these two things, and it is quite easy to answer. Don't get mixed up in the words. Make sure that you are crisp and clear in the terminology, and the answer is quite easy. So this is the second image, is the B and D are after reduction. You can see the lower limbs almost in the anatomical position, and if you look at the X-rays, you can see the head of femur well within the acetabular socket. So this is after reduction. So anterior hip dislocation. Then a child have pigeon chest, rachitic rosary, bowing of legs, enlargement of wrist. Now this is again a very classical presentation of kids. Again a classical presentation of kids. You can see pigeon chest, you can see rachitic rosary, which are actually enlargement of costochondral junction. Bowing of legs, I already told you, this is genu varum, and enlargement of wrist is because of enlargement of biceps, that is the growth rate. So we will see enlargement of wrist, and in fact this is a very classical presentation. The moment you look at the patient, if you look at the wrist of the child, it will be very wide like this, and it gives an impression as if this is a case of the wide wrist. See here, classical for rickets. What you need to give? Obviously you need to give vitamin, right? Then next question, a patient presented to the emergency room after trauma, and the limb was in attitude of flexion, adduction, internal rotation. So I have just kept this question once again. You can appreciate Federer deformity, and Federer deformity post trauma, one can say with confidence that this is a case of posterior hip. Clear? So flexion, adduction, internal rotation. Federer is posterior hip. So don't confuse. You can see in the image also, there is flexion at the hip, there is adduction, the knee is touching the opposite or even crossing the opposite knee, and there is internal rotation like this. So this is posterior dislocation of here, and we discussed about anterior dislocation. You can see abduction, you can see the flexion and there is external rotation. So this is favor deformity for anterior dislocation and this is padded deformity for posterior dislocation. Please don't clear. Then if there is fracture of humerus, which all nerves can be injured. Now I think this has been discussed many times. Radial nerve can be injured if there is fracture shaft of humerus. Ulnar nerve can be injured if there is fracture of medial epicondyle, and median nerve or especially anterior interosseous nerve branch, it can be injured if there is fracture condylar humerus. So please remember these nerve injuries in relation to injuries of humerus. Musculocutaneous nerve has not been described anywhere in relation to fractures of. So with this we can end this session.